Hello and welcome. It's a great pleasure to be here, and I want to thank the organizers for inviting me. Who am I, or better, who are we? My name is Harald Kittler. I'm from the Department of Dermatology at the Medical University of Vienna, Austria, and I'm a dermatologist. But I'm part of a larger group, the Vienna Dermatologic Imaging Research Group, which also consists of Philip Jandl, who doesn't want to see his portrait anymore on the internet, and Christoph Rinner, who is a data scientist. Philip Jandl is a dermatologist and a computer scientist, which I think is a very good combination in this field of research. Now, you probably know us best for creating the HAM-10,000 dataset, which is a benchmark dataset in the field of machine learning and skin cancer diagnosis. Now, when we look at the number of publications published in the last years dealing with machine learning and skin cancer diagnosis, or artificial intelligence and skin cancer diagnosis, we can see a sharp peak here, and this pertains to medical publications, but also to non-medical publications. When we look at the co-authorship network of a subset of the most productive authors in the field, we can see two clusters. One cluster consists of computer scientists mainly, and interestingly, they are centered around the chairman of this workshop. And the other cluster consists of dermatologists. And it is very rare to see a dermatologist like Philip Jandl who is connected to an isolated cluster of computer scientists. So in other words, it is a kind of house divided. We have computer scientists versus physician scientists, and they kind of do their own thing, which I think is not ideal. Now, when we look at the impact of articles, we can see that multidisciplinary articles, meaning articles that have authors coming from the field of dermatology, of computer science, data science, and so on, are much more influential than solely medical articles and solely technical articles. Now, I often review technical articles as well, although I'm a dermatologist. I have a general knowledge of the field of machine learning. I code a little bit, but of course I'm no match to you. But I often read with interest the introduction. And in the introduction, sometimes I have to read sentences like this. Skin disease, the most overwhelming kind of malignancy, manifests when skin cells lose control. Well, this would translate into your language to a sentence like, computer science, the most important type of machine learning, manifests when computer scientists lose control. Now, this is of course nonsense. Or another sentence, benign cancers are classified as basal cell carcinoma and squamous cell carcinoma. Well, this is nonsense to my ears. There is no such thing as benign cancer. And this only tells me that the computer scientists who wrote this have no idea and have no knowledge about the domain of dermatology and skin cancer. How can they solve this problem? Technical skills are not enough, and this is the message that I want to convey in this talk. Now, I will try to show you that domain-specific knowledge is important for you computer scientists. Domain-specific knowledge, I mean domain-specific knowledge in the field of dermatology and skin cancer diagnosis. It's important for you in all aspects, including the formulation of the problem, and collection of data, data pre-processing, modeling, interpretation of results, but also to understand and predict the limitations of your model, and to know the exceptions, and to make the model fit for intended use. And let's go back 4 years, 2017. This was kind of the big bang of deep learning and skin cancer diagnosis, published by Esteva and co-workers in Nature. You can see this study is in the center of many other studies that followed, and most of the other studies are technical studies, and only one study of connected papers is a purely dermatologic study. But this is not the point. The point is that it is important to know that a lot of domain-specific knowledge from dermatology went into this study. And it is no surprise that 3 of the 7 authors of this study were dermatologists. And what type of domain-specific knowledge? Well, the authors created a clever hierarchy of diagnosis that they used to generate two groups. They binarized this data into benign and malignant, and they solved the problem of benign versus malignant, but it is based on a hierarchic tree of more than 700 diseases. This sounds abstract. Let's look what they did. This is the hierarchic tree, and you can see here the realm of skin diseases, which has a subset of benign skin diseases, skin lesions, that has a subset of epidermal benign lesions, that again has a subset of different benign epidermal diseases. And this is contrasted, or has been contrasted by the authors, with malignant epidermal lesions that again is a subset of all malignant neoplasms and so on. And by doing this, they showed us that they could train a model that could differentiate well between these two subgroups of benign and malignant epidermal lesions. And they did the same also for melanocytic lesions, benign and malignant melanocytic lesions. The point is that this problem, as you've seen, is only a subset of the problem that we have in clinical practice. This is what I often see in competitions, like Kegel competitions. I don't have anything against Kegel, but in Kegel competitions or in any other kinds of competition, you have an artificial problem that is not the problem that we are dealing with in reality. It's only a sort of small subset of the problem, and you have to know this. And to know this, you have to have domain-specific knowledge about the big problems in the domain. Now, the next thing I want to discuss is the importance of domain-specific knowledge when it comes to data collection. The very first step of creating a model. In skin cancer diagnosis, we deal with images, and these images come in different flavors. We have overviews, we have clinical close-ups, and we have dermatoscopy images, which have the highest magnification. And dermatoscopy images are the only ones that require a specific instrument. And these different images have different kinds of problems. Dermatoscopy images, for example, are taken with different cameras, and we will come to that. But overview images are difficult because you have to find the lesion of interest, you have to do object detection and so on. Most databases for skin cancer diagnosis, like the ISIC database, contains only dermatoscopy images. Some also contain clinical images, but you have to note that there's a difference, of course. And the ISIC database contains more than 60,000 dermatoscopy images and mainly pigmented lesions. Now, the HAM 10,000 dataset is a highly curated dataset and also includes only dermatoscopy images. And you have to know this. And you also have to know that the images are kind of selected. Why? We included only pigmented lesions, and we had a quality threshold, which means we included only high quality images, which means that probably if you use the HAM 10,000 dataset to train your model, it will not work in daily life, because in daily life you have a lot of low quality images. Now, as said, we selected the images based on what? Because we selected only images from lesions that are pigmented. And we included only 7 diagnoses, which is a subset of the entire problem, as you already know now. And why only pigmented lesions? Because this is a very confined subset with a very specific task. The task is multi-class classification of 7 diagnoses, which cover 95% of all pigmented lesions. So it's a sort of confined problem that is manageable, and this is why we did it that way. And the 7 diagnostic classes can be categorized further into malignant lesions, which is skin cancer, which comes in 3 different flavors: melanoma, basal cell carcinoma, squamous cell carcinoma, which you have to note, this is epidermal and this is melanocytic, and benign lesions, nevi, benign keratosis, dermatofibroma, and angioma. Now, you also have to know, it's also important, that these images, like in many databases, came from different sources, but these sources are also a subgroup of possible sources. For example, there is one source of images that included only images that were taken before 2000. After 2000, polarized dermatoscopy, which is the same instrument but with a different technique, became more popular. There's a difference with regard to the images. For example, you can see here these white lines that you cannot see here on the right side. So the dermatoscopy images are different. And also some images were taken with digital dermatoscopes, and these digital dermatoscopes, they produce a certain effect. You can see here this lower part of the dermatoscopy images. You can see here they all have some kind of reddish halo. They are more reddish than the other images. And this is the type of artifact that you receive when you use this digital system for the acquisition of these images. Now, what does this mean? Here is a UMAP, and here you see all the HAM 10,000 images clustered, unsupervised learning clustered. You can see there are two clusters, and this cluster here corresponds to the images that have been taken with the digital device. And you can see here that the diagnoses are unevenly distributed in the clusters. You can see here that this cluster contains mainly one sort of diagnosis, which is nevus, and only the other cluster contains also a number of other diagnoses. What does this mean? This introduces a kind of bias. Which kind of bias? The digital system that has been used in one source, in one hospital, has been used for a reason, because this hospital is specialized on monitoring patients with multiple nevi. So they will have many images of benign lesions, nevi, which will introduce a spurious correlation. Images taken with device X, with this digital device, are most probably benign, because there are so many benign lesions and only lesions of one class in images taken with this device. And your model for sure will recognize images taken with this device. But now, if you have another situation, if you have another doctor who also uses this digital system, but uses in a different way, she does not use the device for taking many photos of benign lesions. She only uses this device for suspicious lesions, lesions that are suspicious for cancer, only single lesions that will then be biopsied to rule out cancer. But your model that is trained on these images or on a subset of these images will not be doing well in this situation, because it's only a spurious correlation. There is no causal relation between images taken with this device and the diagnosis as suggested in this setting. So what I want to tell you is this contextual information is not in the data, but it is important, and you have to know it, and you only know it if you have domain-specific knowledge. Now there's also another thing. All these data sets are highly imbalanced, as you know. There is a class imbalance. Nevi, a benign melanocytic lesion, is a very common lesion, and many patients, many individuals are covered with nevi, and they are all benign. So we have a class imbalance towards benign lesions, towards nevi. And here there is only one malignant lesion, one lesion that is cancerous in this patient, and you see hundreds of benign lesions. And this is the reality, and this can only be diagnosed with dermatoscopy. You can see here that dermatoscopy contains more information than the clinical overview. The point is, you all have strategies to deal with class imbalance, and you know this better than me, oversampling, undersampling. But there's one strategy that is thresholding, and thresholding is problem dependent, and it needs domain-specific input. For example, if we choose a threshold on the receiver operating characteristic curves to differentiate between benign and malignant lesions, dermatologists use their domain-specific knowledge to choose the optimal threshold. So they don't choose a symmetric cutoff, this would be 50% probability of malignancy, to decide to biopsy a lesion. They choose a lower threshold, which is about 70%, 17%, which means only if the probability is 70%, or if the probability is only 70%, they decide that the lesion should be biopsied. This is an asymmetric cutoff. And it is also, of course, more detrimental to make a mistake in one direction. For example, if you overlook a melanoma, is worse than if you biopsy a benign lesion to rule out melanoma. If you overlook a melanoma, the patient may die. If you biopsy a benign lesion, it's only a scar. So to find optimal thresholds, you need domain-specific insight. Now, selection bias, we talked about this. There's another type of selection bias in the HEM 10,000 dataset and in many datasets. We selected only pigmented lesions. This is a melanoma, but there are also non-pigmented melanomas. This is a basal cell carcinoma. There are also non-pigmented basal cell carcinomas. This is important to know. And why did we choose only pigmented lesions? Because the realm of non-pigmented lesions is much bigger than the realm of pigmented lesions. For simplicity, we choose only pigmented lesions. And if you try to train a model on non-pigmented lesions, you will see, and this is a model that was trained on non-pigmented lesions, that you will see that the model does well for common diseases, because basal cell carcinoma, here you see the network output, and here you see in comparison the dermatologists. And you can see here that the network outperformed dermatologists in the diagnosis of basal cell carcinoma. Why? Because basal cell carcinoma is usually non-pigmented, and it is common. Also, it outperformed dermatologists with regard to squamous cell carcinoma, because it's usually non-pigmented and it's very common, and you had a lot of training cases. But melanoma is usually pigmented, and it's only rarely non-pigmented, and you had only a few cases in your training set, and the dermatologists outperformed the network because dermatologists know how to diagnose non-pigmented melanoma, because they know that it exists, and you probably, your network doesn't know that it exists because it was not included or underrepresented in your training set. For example, this here is an example of a non-pigmented melanoma, an amelanotic one, and here you can see the output was dermatofibroma, which is a benign diagnosis, and the probability of malignant melanoma is 0%. Now, there is also another kind of bias in data collection, which is verification bias. Verification bias means that many data sets have only lesions included that are histologically verified, that have been biopsied, and the diagnosis is verified by a pathologist. And this is problematic because then you include only lesions that are suspicious, and you miss the realm of lesions that are not suspicious. This you also have to know. And you also have to know that pathologists who diagnose these lesions that have been biopsied may err, and there is overdiagnosis. Melanoma is, now there is a large discussion in the field that we overdiagnose melanomas, and too many melanomas. And this means that any algorithm that you create will inherit and amplify all the implicit biases of the people who collected the lesions and who decided on the ground truth, including the pathologists who made the diagnosis. So, if you collect images from a source where the pathologists tend to overdiagnose, your algorithm will inherit this kind of bias, and you have to notice. I see many papers that contrast the accuracy of their algorithm with a benchmark algorithm, which is fine. But for clinical purposes, there is only one benchmark, and these are humans. These are physicians. And if you really want to make an impact in the realm of machine learning, you have to compare your model with physicians. And this is what we did, and we compared not only one computer algorithm, we compared more than 100 computer algorithms in a competition, in a well-defined problem, which is only a subset of all problems, with more than 500 physicians, humans, with different level of expertise. I will not go into the details because of time, but we did a reader study where we gamified this for the readers, because otherwise you cannot motivate 500 humans to label or to diagnose hundreds of lesions. So we gamified the problem and we had a large reader study. This was published in the Lancet Oncology. And you can see here, what you can see here is the red line indicates that there is no difference between the machine learning algorithms and the human observers. And on the left side, you see human underperformance. And you can see the humans were no match against the computer algorithms. This should be the benchmark. Experts. And ideally, you also test your algorithm and you compare it to a range of human expertise, not only to experts, but also to beginners. Now, there is another issue with regard to the importance of domain-specific knowledge, and this is personalized treatment decisions. Personalized treatment decisions are, for me at least, AI hard problems. They are much harder than just multi-class probability, and you cannot expect that your model, no matter if it won a Kaggle competition or not, will work as a standalone device without a human interfering, without a human in the loop. Currently, we are far away from solving AI hard problems, and all these models need human assistance. Now, what I want to say is, when we go back to this problem of the 7 diagnostic classes, when you need human assistance, you have to check how your model works in collaboration with humans. Now, and we tested that. This is, I think, the holy grail of testing the accuracy of your model. You have to test the accuracy of your model in collaboration with a human interpreter. And this is a physician mainly. And we did that. And first, again, we gamified it. We showed the readers a pigmented lesion, first without AI support and then with AI support. And we gave them different types of output. First, we gave them the multi-class probability. Remember, these were 7 classes. Then we gave them binary probability, benign versus malignant. And then we gave them multiple images that are similar to the image in question, but with known diagnosis. This is content-based image retrieval, you know that. We tested these different outputs, and you can see here that it depended, the time needed for the humans to interact with the algorithm depended on the output. Here you have the time to answer for content-based image retrieval, a very long time, and here for multi-class probability, a very short time. And because time is an issue, because physicians never have time, the physicians tended to ignore the content-based image retrieval solution for the output. And also, you can see here the improvement was only visible when you gave them multi-class probabilities, but not content-based image retrieval. So you have to streamline your output to your users, to the physicians. And in this kind of problem, the multi-class probabilities were better than other outputs, like the binary output or the content-based image retrieval. But for every problem, it can be different. Content-based image retrieval can be, for example, beneficial for pathology and so on. You have to find this out. And for this, you need to know how the users will use your system. Now, what we also saw is that beginners, intermediates, and expert, they had different types of benefit from the computer assistance. You see here that beginners, they benefit the most, intermediate users don't benefit so much, and experts benefit the least, but beginners benefit the most. And you can also see here that beginners benefit no matter if they're confident with their initial diagnosis or if they're not confident. Whereas experts only benefit if they're not confident with the diagnosis. So in other words, beginners will change their diagnosis, no matter if they're confident in their initial diagnosis without AI support or if they're not confident. You have to notice, because what we did was something nasty. We provided the users not with the correct diagnosis, we provided the users with a false output. A kind of, we simulated a rogue machine, a rogue computer algorithm that always gives the false, not always, but in some cases, gives the wrong prediction. And then we tested again if they improved the diagnostic accuracy with AI support or if they got worse. And you can see here, this is with regular AI support and this is with wrong AI support. And you can see here that all, even experts, got worse or underperformed in comparison to their expected accuracy when they were confronted with wrong AI predictions. So, if you benefit from AI, you need to trust AI. But if you trust AI, you're also susceptible to perform below your expected performance if the AI system is wrong. So finally, I want to talk about knowledge transfer. What does it mean? Remember the Lancet Oncology study? The humans lost. Why did they lose? Because machines were especially good in one type of diagnosis, which is pigmented actinic keratosis. No matter, you don't have to know especially what it is, but it is one specific type of diagnosis that is related to UV damage. And humans did not so well with this diagnosis. And this is a pigmented actinic keratosis. And what you see here in the surrounding skin is severe chronic sun damage. This is important. And you also see other criteria. I do not want to go into the details. But what is important is these two lesions look very similar. This is a pigmented actinic keratosis, but this is not. This is a melanoma. And you can see here severe chronic sun damage, and you don't see the severe chronic sun damage here in the surrounding skin of the melanoma. Now, humans usually look at the lesion and not at the background, because this is where the money is usually. This is where the information is. But when we looked at the class activations for all diagnostic categories, for all the 7 diagnostic categories, we saw something interesting. The AI model had a higher class activation for the background in pigmented actinic keratosis than for all other diagnostic categories. So there was a lot of background attention. And now what can you conclude from this? You can say it's a spurious correlation. There's something to do with, for example, with the image source. But if you have domain-specific knowledge, you can also come to another conclusion. And what is this conclusion? You can conclude that pigmented actinic keratosis are caused by UV damage. So if I see severely chronic sun damaged skin in the surrounding, then it could be pigmented actinic keratosis, which it is. If there is no severe chronic sun damage in the background, then it could not be pigmented actinic keratosis. Now, this was an insight gained from AI, but only via domain-specific knowledge from a dermatologist. Now, the holy grail would be, could we improve humans if we tell them? If we tell them the clue, and we tested this, and lo and behold, you can see here the diagnostic accuracy before teaching them the clue and after teaching them the clue, and they improved, especially for pigmented actinic keratosis. So, domain-specific knowledge was necessary to translate the results of class activation maps into a human understandable concept. So this is also why we need domain-specific knowledge. Now, I hope that I gave you a glimpse into the importance of domain-specific knowledge when it comes to machine learning for skin cancer diagnosis. And technical skills, and you all are technically skilled, but technical skills alone are not enough. They're important parts of the problem, are not captured in the data, and you have to know this. Now, my advice for you would be, visit a healthcare facility to get a feeling for the problem from the physician point of view. 3 weeks are usually enough, and I invite you to come to Vienna to our group. We have a big hospital behind, and you can learn a lot of domain-specific knowledge in just 1 week. If this is an option for you, write me an email here, harald.kittler@meduniwien.acat, or to Philip Channel. Thanks for your patience, and I hope to see you soon. Bye-bye.